Okay, so let's start with the questions. Thank you, Mohammed, for this excellent summary. Let's say, obviously, we can break up what you said in something like 25 journal clubs, starting from the importance of the clinical diagnosis. And this is where our professor Hassan Maghrabi is asking a question. And he's highlighting that maybe we, yes, yes, past this topic, let's say, which is the common systemic manifestations with endometriosis. So we know that endometriosis can cause infertility. What else can draw your attention to a patient with endometriosis, especially that not all these patients have the so-called, even if I don't like this term very much, the chocolate cyst. Some of them have deep endometriosis, some of them have asymptomatic lesions. So how would you suspect endometriosis rather than the problem of infertility, the systemic manifestations? When can you open your eyes like this and try to evaluate this patient suspecting that she has endometriosis?
So first, if a case complaining of number one, pain with infertility, complaining of dysmenorrhea while she was adolescent, complaining of dyspareunia after marriage, maybe complaining of dyschezia or dysuria. Also, when you do a ultrasound, you can see any manifestation of endometriosis, such as absence of sliding tests. While you are doing ultrasound, you may find adenomyosis with bulky uterus. If you have endometrioma or persistent free fluid inside the pelvic cavity, inside the pelvis while she is menstruating, I think all of these raise the flag of endometriosis or make you suspicion or that she has endometriosis.
Thank you. We have a colleague who is raising her hand, Azza Rizik. Azza, are you still around? Okay, then I will pass to the second question, very, very important question from Professor Maghrabi, and he's asking about the incidence of deep endometriosis. He's asking us to highlight the incidence of deep endometriosis in patients with adenomyosis. Fine, let's start by a fact that deep endometriosis is underdiagnosed. And it needs a particular level of suspicion and a particular level of expertise to diagnose it either by ultrasound or by MRI or by laparoscopy even. So deep endometriosis is underdiagnosed. This is not my opinion. This is the consensus between the endometriosis experts. The incidence of deep endometriosis is about 15 to 30% of patients with endometriosis in general. So let's say 1 in 5 to 1 in 3. Every 5 patients that come to you with endometriosis, one of them has deep endometriosis. However, there is a very famous paper by Katerina Exakoustos, who is one of the most famous sonographers in the world, who diagnosed the isolated ovarian endometriomas in only 15% of the cases, which means that every 100 patients that you will see, 85 of them might have some deep endo and only 15 will have ovarian endometriosis. Half of the patients with deep endometriosis have adenomyosis, 40 to 50%. So this all obviously, and you are all experts in infertility, are not, has an impact, as you brilliantly mentioned, Mohammed, on the implantation rate and on the outcome either of spontaneous pregnancy or ART. And this is something that maybe next time, if our colleagues are happy or are available, would like to or approve this topic. I know that Ahmed Khalifa has been to a very, very famous center that I'm proudly part of it in Bologna in Italy, and he learned a lot about ultrasound diagnosis of endometriosis. Maybe next time we can discuss the idea paper about endometriosis if our colleagues in the journal club agree. So I just wanted to highlight the importance of the question of Professor Maghrabi, and the point that he wants to highlight is don't ignore adenomyosis, don't ignore deep endometriosis, try to focus on this. A chocolate or whatever you call it, ovarian endometrioma, is usually a sign of a global disease that can be affecting the deep compartments of the pelvis and also the uterus, causing adenomyosis. We have another message here, okay? And Azza is not here. Guys, write questions in the chat group. Don't be shy. We are here to answer your questions and to make it interactive as much as possible. So I would benefit from the presence of this lovely panel and also from Professor Maghrabi yes, learning as much as I can and discussing all the doubts that I have. Here, Tamer, if you want to answer this question, here I know that you are a great laparoscopist as well as infertility specialist. So do you advise and do laparoscopy for infertile patients with probable endometriosis? And this is a very, very tricky question. So what do you think? Do you advise laparoscopy, a patient that you doubt that she has infertility? Do you advise laparoscopy for probable endometriosis, yes or no?
First of all, it's my pleasure to be here with you, my professors and my colleagues. Dr. Hassan Maghrabi is the head of our professors, and we learned so much from him. Dr. Mabrouk is one of the idol we see. He's very great laparoscopist in the world. My colleague, Dr. Muhammad Mahdi and Ahmed and Dr. Gibril. It's very nice to be here with you in this first journal club in the endometriosis of EFRI. To answer this question, I think the guidelines itself cannot answer this question. They do first say that the gold standard for diagnosis for endometriosis is the laparoscopy. Then in the latest ISHRI guidelines, they remove the laparoscopy from to be the gold standard for diagnosis. So even the guidelines is hazy to answer this question. But for me, my opinion, and this is what we want to share, that the laparoscopy is a tool to do something inside the laparoscopy. It's not a tool for diagnosis. I don't think that the patient go for operative theater just for diagnosis. I think it's very hazardous for to say that if you want to diagnose something, you will do an operative procedure. So for diagnosis, I don't think we have to diagnose endometriosis with laparoscopy. You have to do something in the laparoscopy to either enhance fertility or to do surgery for definitive treatment for this patient, either for pain or for enhancing fertility, for something either for closing hydrosalpinx or removing the tube or whatsoever. So I think this is my opinion. If I'm not answering all the question, please let me.
I think, who does disagree with Tamer? Does anyone disagree with Professor Tamer Hosni? Okay, so no disagreement, Tamer, but I would rephrase what you said, if you allow me. So here, I think the message also that Professor Maghrabi, with all his experience, is trying to deliver here is we need to study and evaluate our patients. And it is individualized, the line of management that we offer to our patients. And I think this is what you are trying also to highlight, Tamer. So not all patients are the same. There is no one size fits all. A patient like Muhammad al-Mahdi was showing now, who has low ovarian reserve, low AMH, severe male factor infertility, no pain, and her main objective is fertility. And you think that she might have endometriosis, what would you benefit her by doing a diagnostic laparoscopy if she doesn't have, I don't know, hydrosalpinx or something like that, that you go inside to improve the probability of success of her IVF? So I think before deciding, first we have to decide with the patient. Second, we have to tailor our decision after counseling the patient about the risks and the benefits that she would face from every medical or surgical option that we are offering to her. Third, if there is an intervention, whatever it is, that has a known risk and a probable benefit, then in medicine, they call this a low value care, and we should avoid low value care in cases with endometriosis. So Amin Sami, please, you're raising your hand. Ask your question, please. Dr. Amin Sami. You can ask your question, please, or write it in the chat. You raised your hand by mistake. Can someone allow Dr. Amin Sami to speak, please?
He's allowed, Doctor.
Okay, Amin, tawakkal ala Allah. Ask the question. Okay.
Hello, everyone. Do you hear me?
Very clearly and very
Okay.
strongly.
Okay. Thank you, everybody, for this lecture. My question was,
دكتور امين، لو انت فاتح من الموبايل واللابتوب اقفل حاجه منهم. ما ينفعش تفتح الاثنين مع بعض عشان هيعمل ايكو.
Otherwise, you can write the question in the chat and we are very happy to respond. Dr. Ahmed Khalifa is also, Dr. Amin, can you please write it in the chat or close one phone or the laptop and make only one source of sound for yourself? Here, Dr. Ahmed Khalifa is opening the fire and asking about resecting adenomyosis for the sake of fertility. And I think we will fire you back, Ahmed, and ask you, what do you think? So, yes, you read a lot, and I know that you are one of those who read deeply in the literature. So tell us, what do you think? A focal adenomyosis for the sake of fertility, does that make sense or it doesn't? And if you do it, how you do it and why you do it?
First of all, it's a real pleasure to be a part of this Journal Club meeting and be among my professors and colleagues, and Dr. Maghrabi, Dr. Mabrouk, Dr. Ahmed Gibril, Dr. Mohammed Al-Mahdi, and Dr. Tamer. Concerning focal adenomyosis, till now, I think it's quite debatable in this topic. Either it needs to be removed, and either it's proven that it can improve the pregnancy rate since after removal of such lesion, or we can give the patient a chance either by spontaneous pregnancy or by an ERT cycle, and after embryo transfer, and give the patient a chance to see the pregnancy rate in the presence of this lesion. So I don't think that resection of such lesions may give a significant improvement in pregnancy rate. Although I think that removal of such lesion may increase the complications during pregnancy, either by increasing the rate of morbidly adherent placenta or increasing the rate of ruptured uterus during pregnancy. So I think that if this focal adenomyosis is not significantly distorting the uterine cavity, so the patient can go through her management either by assisted reproductive technology or by surgery followed by ICSI or IVF without removal of this focal adenomyosis.
أستاذنا الدكتور حسن المغربي، رأي حضرتك إيه؟ What do you think about adenomyosis؟ الدكتور أحمد جبريل لسه مش معانا أعتقد. أستاذنا الدكتور حسن المغربي، رأي حضرتك إيه بخبرة حضرتك with your experience in this field؟ Shall we remove or shall not we remove? Okay, so here, Dr. Ahmed, who disagrees with Ahmed? Tamer and Mohammed Mahdi, Dr. Maghrabi, Dr. Ahmed Gibril, and our colleagues, who disagrees with Ahmed? Who would take a patient with focal adenomyoma to theater to remove the adenomyoma as a first line of treatment and convince her that this is the best solution or the best option for her?
I agree with Ahmed.
Great. And yes, please. We agree that as a first line of management, this is not the case. Tamer, what do you think?
I agree that this is not the first line of management, but in case the focal adenomyosis is not compressing the cavity, because it may affect the cavity and the implantation if it compresses the cavity. So the site of the local adenomyosis, I think it's one of the important item to be fulfilled first, either by 3D or by MRI, to exclude that this local adenomyosis may compressing the cavity or distorting the cavity. So impairs either implantation with assisted reproductive techniques by ICSI or whatever, or impair implantation in the patient with for spontaneous pregnancy. I think this is the only case, in my opinion. I don't remember anything else.
So for my fertility specialist colleagues, I would rephrase the question in another way. So we all agree that as a first line of management, we will not remove the adenomyoma unless it is compressing the cavity or distorting the cavity or intracavitary or whatever. My question here is, what if this patient had failed 3 cycles of IVF or failed implantation 3 times? She ovulates well, we control their stimulation, you implant the embryos, and the recurrent implantation failure. And let's say that this is the only one that you might find. What would you do?
If there is unexplained recurrent implantation failure and the adenomyoma near the junctional zone or affection, or there is affection of the junctional zone of the endometrium, I think it's a good choice to remove adenomyoma. Like simple myoma compressing or near the junctional zone or associated with recurrent implantation failure.
طبعا in difficult topics لا يفتى ومالك في المدينة. We will ask Malik. So please, Professor Maghrabi, we were discussing, Ahmed Khalifa has raised this issue of a focal adenomyoma. If we can do this surgery for excision of the focal adenomyoma as a first line of treatment for a patient with infertility, and what if this patient has recurrent implantation failure and the only thing that we find is the focal adenomyoma? What would you recommend with your experience?
Thank you very much, my dear friend. I'm not the experienced, you are the experienced. So my question is, are there control studies showing that intervention versus no intervention increases the outcome in the condition that you just described?
No. As far as I'm aware, there are no controlled trials, and there is no strong evidence to support this or that. But we would like also to highlight the fact that, first of all, there are other treatments for dealing with an endometrioma, a focal endometrioma, rather than surgery. I'm not sure if they are available now in Egypt, yes or not, but my understanding is that there is a focal ultrasound treatment, and this is not that expensive, and it's happening in many countries now. There is also the radiofrequency ablation of the adenomyoma. There is the focal MRI-guided ablation of the adenomyoma. These things, in terms of, and the treatment, the new one, which is the Sonata. These ablations, what they do is that they reduce the inflammation and neomyogenesis in the adenomyosis and improve the status of the inflammation of the uterus. There is no randomized trial, but very promising results from retrospective studies. And I have to say that I did a lot of radiofrequency ablations of focal adenomyomas, and they're good. I'm not sure how many cases I performed so far for deep endometriosis, but I can tell you that the cases that I removed focal adenomyomas are not more than 12. So only a dozen of patients in all these years. Why? Because everyone is hesitant and reluctant before deciding to remove an adenomyoma. And again, why? Because this is a potential benefit, and as Professor Maghrabi said, there is no solid evidence to support that we will improve the patient's fertility or the live birth rate. However, there is a documented risk of uterine rupture during pregnancy with this. And technically, these are not easy cases. If you are about to do it, please refer the patient to someone who is experienced. And I have to tell you more. In laparoscopy, I'm not sure if laparoscopy is the best approach for these cases. I used to do them in laparotomy, but recently when I started doing robotic surgery, robotics is much better than both of them. I'm saying this because there is no plane of cleavage. Removing the adenomyoma is technically very difficult. Reconstruction of the uterus is not an easy job. And this is where healing can be compromised and the patient can have a rupture of the uterus during her pregnancy. Ahmed, have we replied to your question in a proper way? Okay, if you are still here, I hope you tell us something. Okay, Amin wrote his question.
Totally, Professor, yes. Thank you very much.
Amin wrote his question and he said, I couldn't write till now, with or without endometriosis, when shall we go for salpingectomy in case of hydrosalpinx before the first IVF trial, or in case of recurrent implantation? Thank you. With simple disconnection or with drainage or removal. So if I understood well, our colleague Amin Sami is asking about dilated tube endometriosis. When would you go to remove the tube, and when would you do clipping or disconnection of the tube before the first IVF trial? I hope I understood well. What do you think? Mohammed, you do these surgeries frequently.
Yes. If there is a hydrosalpinx, small hydrosalpinx with low ovarian reserve, I think tubal clipping or bipolar coagulation and the cut is more than enough for this case. If you have a mega hydrosalpinx frozen, mega hydrosalpinx, large hydrosalpinx with good ovarian reserve, I think you can go for a salpingectomy to avoid reaccumulation and to avoid pelvic abscess. But take care, salpingectomy may affect ovarian reserve. So you should measure ovarian reserve carefully before going for surgery. So you can do either tubal clipping or salpingectomy. And by evidence, by studies, there is no upper hand for salpingectomy or tubal clipping regarding pregnancy outcome after IVF. So the same results.
Great. I agree. Anyone else disagrees with what Dr. Mahdi said? Okay.
I just want to add something very small. I totally agree with what Professor Mahdi stated, but I will add also to the importance of the means of diagnosis of hydrosalpinx. It should be ultrasound, not hysterosalpingometry.
Great.
So the hydrosalpinx that is to be removed has to be diagnosed by ultrasound, not by hysterosalpingometry.
Oh, last but not least, here we have two quick questions, but I would like also to emphasize the point, Professor Maghrabi, as well, is, and for my colleagues who are attending and listening to us, these cases are done to be and are programmed to be performed by experienced surgeons. Please, please, please. If you're not experienced, please refer the case. The tube sometimes is very adherent and it's a frozen pelvis, and you go inside to improve her probability of having a successful IVF, and the problem that is created is much bigger. And I can tell you that in these cases, if an abscess happens, it's a nightmare. An abscess over an endometrioma or a deep endometriosis is a nightmare. This is very important, and we have to be intellectually honest in dealing with these cases and referring them. Another thing, which is if you decide to do IVF, also oocyte pickup in these cases is not an easy job. I'm sure that my colleagues who do frequently oocyte pickups understand that with deep endometriosis, especially if there is involvement of the rectovaginal septum or the vagina or the rectum, when everything inside is glued together, these cases are a bit tricky, are a bit risky. So please, it's very, very important not to take a risk, because this might compromise not only the patient's fertility, but also the patient's life. Here I have a question from Azza. She's asking about Dyanogest before surgery. If someone uses Dyanogest before surgery to improve the surgical field and the ovarian reserve. Tamer, yes, please.
I think the question about Dyanogest before surgery.
Yeah.
Or you answer my raising hand.
No, this is the question. You answer it, and then you ask
okay.
your raising hand. Yes.
It's okay.
We are already 2 minutes after the time, but yes, please, I'm happy to.
Answering I think that Dyanogest, I don't see that there is a rule for Dyanogest before pregnancy or enhancing this patient for going pregnancy. I think it may be a rule for treatment for pain. This is my opinion, and I think that Dr. Mahdi also illustrated that there is no treatment before any allowing this patient for fertility treatment. So prescribing treatment for before fertility, I don't think that Dyanogest has a rule. And if I'm wrong, please let me know.
I think we all agree with you, Tamer, and also I wanted to thank all the colleagues for their kind interaction and the kind collaboration and questions. I am sure that this journal club, this first version of our journal club, will help all of us to open and to think about what and how we can change our practice dealing with patients with endometriosis and fertility. So, because we are now, thank you very much, and thank you for all our colleagues who are thanking us. We are very committed to start on time and to finish on time because we appreciate the commitment and everyone's time. So remember, last Friday of every month, we will meet here in the Endometriosis Journal Club of the EFRI Endometriosis Interest Group. Today, we spoke about endometriosis-related fertility. We are very thankful for your participation. And next time, we will ask you about the topics that you want us to discuss. We will send you all emails. And we will please wait for your reply. Send us the cases, the questions that we couldn't answer. Dareen, who is, I would like absolutely to thank her and thank Dr. May Nahrawi as well for the great effort that they're doing behind the scenes. We'll take the questions, we'll send them to us. And remember, last Friday of every month. See you all and wish you all the best. Thank you all.